The series. This is a chapter 15, hereditary fundus dystrophies, and in this part we are going to discuss about the albinism. Introduction. Albinism is a genetically determined heterogeneous group of disorder of the melanin synthesis in which either the eyes alone, ocular albinism, or eyes, skin and hair, oculocutaneous albinism may be affected. So there are two types, ocular albinism and oculocutaneous albinism. So oculocutaneous consists of the eyes, skin, and hair. And albinism is basically there is a disorder of the melanin synthesis. The latter may either be tyrosine positive or tyrosine negative. The different mutations are thought to act through a common pathway involving the reduced melanin synthesis in the eyes during development. Tyrosinase activity is assessed by using the hair bulb incubation test, which is reliable only for 5 years of age. Patients with oculocutaneous and probably ocular albinism have an increased risk of a cutaneous basal cell and squamous cell carcinoma. So, carcinoma are more in the cases of an albinism, and there can be tyrosine positive albinism and tyrosine negative. Patients with oculocutaneous albinism are at increased risk of a cutaneous basal cell and squamous cell carcinoma and should take precautions to avoid exposure to sunlight. So, tyrosine negative oculocutaneous albinism, which is basically more severe of albinism. The individuals who have tyrosine negative complete albinism are incapable of synthesizing any melanin and have white hairs and very pale skin throughout with the life with a lack of melanin pigment in all ocular structure. The condition is genetically heterogeneous, usually with autosomal recessive inheritance. So it is more severe. The eyes are white, the face is white, the hairs are white, and signs of visual acuity is usually less than 6 by 60 due to foveal hypoplasia. So visual acuity will be decreased because of the foveal hypoplasia. Nystagmus is typically pendular and horizontal. It usually increases in bright light and tend to lessen in severity with age. So nystagmus will also be present. Eyes is diaphanous and translucent, giving rise to a pink-eyed appearance. So iris will be translucent. The fundus lacks pigment and shows conspicuously large choroidal vessel. There is also a foveal hypoplasia with absence of a foveal pit and poorly formed perimacular vascular arcade. So the choroidal vessels will be visible. There will be the absence of a foveal pit, and there will be the formed perimacular vascular arcade. The optic chiasm has a fewer uncrossed fibers than normal, so the fibers will not get crossed. The majority of the fibers from each eye cross to the contralateral hemisphere. So there will be the most crossed fibers to the contralateral hemisphere. This can be demonstrated with visual evoked potential. Other features include high refractive errors of various types, a positive angle kappa, squint, and absent stereopsis. So this is a signs in a tyrosine negative oculocutaneous albinism. A is showing white hair and very pale skin. B is showing marked iris translucency. C is showing picked eye appearance. D is showing severe fundus hypopigmentation and foveal aplasia. Next is a tyrosinase positive oculocutaneous albinism. Individuals who have tyrosinase positive incomplete albinism synthesize variable amount of melanin. So there will be the melanin production, but it will have variable amount. Their hair may be white, yellow, or dark red and darkens with age. So hair will not be so much white, but it will have a yellow appearance or red or darken with age. Skin is pale at birth but usually darkens by 2 years of age. Inheritance is also is usually autosomal recessive. Mutation in at least 2 distinct genes can be causative. Ocular signs, visual acuity is usually impaired due to foveal hypoplasia. So foveal hypoplasia will also be present in this. Iris may be blue or dark brown with variable translucency. Fundus may show variable hypopigmentation. So tyrosine positive is less of the severity than the tyrosine negative. So there's two systemic association, Chediak Higashi and Herman Sky-Putlik syndrome and Waardenburg syndrome. A rare autosomal recessive disorder arising from the mutation of the lysosomal regulator protein. This lead to a failure of a phagolysosome formation and recurrent pyogenic infection. especially staphylococcus. So there will be the lysosome will be deficient, and enzyme will be deficient, and it will lead to the failure of the phagolysosome, and which will lead to the recurrent pyogenic infection. Whereas Hermann-Pudlak syndrome is an extremely rare autosomal recessive lysosomal storage disease with platelet dysfunction. There will be easy bruising and mm, mm, excessive bleeding. In some cases, pulmonary fibrosis and granulomatous colitis with bleeding may occur. So most of the time, its major is that it will have a decreased platelet function. Then there is a Waardenburg syndrome, which is an autosomal dominant condition with a range of a systemic presentation, including a white forelock, poliosis, cyanophores, which is basically monobrow. The brows are attached to each other, deafness, and sometimes limb and neurological anomalies. Ocular features include lateral displacement of medial canthi, hypochromic irides with segmental or total heterochromia. So heterochromia can also be present, and segmental heterochromia can also be present, and choroidal depigmentation. So this is a tyrosine positive oculocutaneous invalidism. A is showing fair hair and normal skin color. B is showing mild fundus hypopigmentation. So this is a Waardenburg syndrome. And with iris heterochromia, segmental in the right iris, and cyanophores, carriers of the X-linked ocular albinism. So ocular albinism is only when the ocular part is being involved. In this period, involvement is predominantly ocular with normal skin and hair, although occasionally hypopigmented skin macule may be seen. So sometimes there is a hypopigmented skin lesions can be seen. Inheritance is usually X-linked recessive, but occasionally autosomal recessive. Female carriers are asymptomatic but may show partial translucency, macular stippling, and mid-peripheral scattered area of depigmentation and granularity. So mid-peripheral area, it will have a depigmentation and granularity. Affected males have hypopigmented irides and fundi. So next is a cherry red spot at the macula. So cherry red spot is when the because of the fovea it has a less layers, so that is why the underlying pigment is visible. So that is known as a when the surrounding areas is becoming white, there is a foveal fovea will have a darkish appearance, which is known as a cherry red spot. A cherry red spot at the macula is a clinical sign seen in the context of the thickening and loss of transparency of the retina at the posterior pole. The fovea is the thinnest part of the retina, allowing the persistent transmission of the underlying vascular choroidal hue when the surrounding retina become relatively opaque. Causes include, so there are metabolic storage diseases, there are central retinal artery and cilioretinal artery occlusion, retinotoxicity, commotio retinae, and miscellaneous. So, in the metabolic storage diseases, a group of rare inherited metabolic diseases, often enzyme deficiency, leads to the pathological accumulation of the lipid-based material in various tissue. So, because of the lipid metabolism is being deficient, the lipid is being accumulated in various tissue. With passage of time, the spot become less evident due to retinal nerve fiber layer degeneration and conjunctive optic atrophy seen. They are almost exclusively autosomal recessive. Some individual storage disorders are. So there is a GM1 gangliosidosis, which is generalized. So it will have a neurological features are severe with death typically at the age of 2 years. Subtle corneal clouding can occur. Mucolipidosis type 1 sialidosis, a late onset form, features myoclonus and seizures. So ML1 will show have a myoclonus and seizures, but is incompatible with the normal lifespan. A more severe form causes severe neurodegeneration and death in early childhood. Corneal clouding and optic atrophy may be seen. So in this type, the corneal clouding and optic atrophy will also be seen. GM2 gangliosidosis, the encompasses two conditions, Tay Sachs disease and Sandhoff disease. In both, there is a progressive neurological deterioration with early blindness and death. So GM2 will have a neurological deterioration. Then there is a Niemann-Pick disease of the three main types, A and C. Only the first two features a cherry red spot. Abnormality, ocular motility occur in type C, which is a chronic neuropathic. Then there is a Farber disease, which is a systemically aphonia, dermatitis. There can be lymphadenopathy, psychomotor retardation, renal and cardiac pulmonary disease with other ocular features additional to cherry red spot development include pangiquera like conjunctival lesions and nodular corneal opacities. So Farber disease also have a cherry red spot. Then the central retinal and the cilio-retinal artery occlusion, retinal clouding results from the edema. This appearance is an acute sign only. So after sometimes it decreases, cherry red spot decreases. Retinotoxicity due to specific agent include quinine, depsone, gentamicin, carbon monoxide, and methanol. So these drugs can also cause cherry red spot, quinine, depsone, gentamicin, carbon monoxide, methanol. Then is the commotio retinae, which is basically edema due to blood trauma. Miscellaneous, the term can be used more loosely to encompass a variety of conditions, giving a dark or a reddish central macular appearance such as macular hole. So that's it for the chapter 15. See you in the next lecture.